Okay, good afternoon, everybody. Thank you for joining us today. Uh, we have a few housekeeping items first, but I wanted to introduce myself. My name is Alexandra Donovan. I'm a medical oncologist here at the Calaway-Young Cancer Center at Valley View Hospital. And in light of Skin Cancer Awareness Month, today we're going to spend a little bit of time learning about various types of skin cancers and what you can do to help protect yourself. So just to address a few housekeeping items before we get started, you can submit questions through the Q&A chat on the bottom of your screen, and your questions could either be answered live at the end of the presentation, or we may be able to send some messages afterwards, and we'll try our best to answer your questions. But we can't answer any questions that have any private health information. So we ask that you keep it general. That would apply to everybody. And with that, we'll go ahead and get started. All right. So again, this is in light of Skin Cancer Awareness Month. Just want to teach a little bit about awareness and prevention. So skin cancer is actually the most common form of cancer in the United States. As a medical oncologist, we treat all kinds of cancer, all stages of cancer, and we have many different types of therapy. Most of the cancers we're going to talk about today are early stage skin cancers where we have the best opportunity to intervene. And most early stage skin cancers are actually treated by a dermatologist. You would only see a medical oncologist if you needed some more advanced therapy down the road. So most of this really applies more to a dermatologist. But melanoma and all skin cancers are very common. There are about 5.4 million cases of non-melanoma skin cancers each year in the US. Those are most commonly basal cell carcinoma or a squamous cell carcinoma. I think many of you right now can think of a few people you know who've had one of these and have had to have surgery for such. About 1 in 5 Americans will develop a skin cancer by the age of 70. So that's many people you know. And the cost is pretty significant to our healthcare system. The cost of treating cancer annually in the US, we estimate, is about $8.1 billion. So that's not because of the systemic therapy we're giving for more advanced stages, but largely due to the cost of the recurrent surgeries that need to happen. So for non-melanoma skin cancers, we estimate about an annual cost of $4.8 billion. And then for melanoma, which is a more serious skin cancer that we'll discuss, cost is about $3.3 billion a year. Melanoma is the fifth most common type of cancer in the United States, at about 100,000 new cases of melanoma each year, and a little under 10,000 pass away from melanoma each year. Still, the most common cancers are breast cancer, prostate cancer, lung, and colon and rectal cancers. We don't see a lot of lung cancer in Colorado. We do, but not as many as other states, and that's because of our healthier lifestyle. The American Cancer Society estimates that the lifetime risk of melanoma is about 1 in 33 for Caucasians. So that's about 3% risk. And in those with more pigmented skin have actually more protection. So lower incidence in African Americans and Hispanics. Melanoma is more common in men overall, but for women under the age of 50, it's actually one of the most common cancers is melanoma for women under the age of 50. And then the risk of melanoma increases with age. So who is at risk of developing skin cancer? Those with fair skin, blue eyes. We think of blonde hair, blue eyes, and fair skin, actually the highest risk. Redheads also high risk of melanoma, a personal family history. So if you've had melanoma yourself, or if you've had a family history of melanoma, you're at higher risk of getting melanoma or any other type of skin cancer. Sunny climates, living outdoors a lot of the time, living at high elevations can increase your risk of skin cancer. History of tanning bed use absolutely increases the risk of skin cancer, and we'll talk about that later. And then those who are immunocompromised, more so not people who are on chemotherapy for short periods of time, but people who have undergone an organ transplant and are on chronic immunosuppressants, or some rheumatologic conditions requiring chronic antisuppressant use. Immunosuppressant use can increase your risk of skin cancer. And where and how you live matters. So we get a lot of sunshine in Colorado, and our elevation also has something to do with our exposure. So in Seattle, for example, they get about 2,000 hours of sun a year versus in Denver, at least 3,000. We live in one of the sunniest states, so we have more chronic sun exposure over time. And elevation increases our risk of sun exposure as well. So for every 3,000 feet of elevation we gain, we increase our UV exposure by about 10 to 12%. So being up here in the Roaring Fork Valley, we're a little over 6,000 feet. At the surrounding mountain areas that we visit every day, we're at 8 to 9,000 feet. So really increasing our ultraviolet ray exposure. And also thinking about things that can reflect the sun, increasing our exposure. Not only are you getting it from up above coming down, but sun reflects off things like snow, can reflect up to 90% of UV rays. So you're almost getting a double dose when it reflects off the snow and comes back at you. And same with sand. Very white sands have a propensity to reflect sunlight and increase your sun exposure. Interestingly, so these are ultraviolet radiation maps across the US, and ultraviolet radiation is what causes skin cancers. We have melanin in our skin that helps actually block out sun and UV rays, but it's when the UV rays are in excess that they can get into the skin and cause DNA damage, and that's what causes skin cancer. And so from UV exposure is the risk for getting any kind of skin cancer. And from April through September, really our summer months, we in Colorado, if you can see my pointer here, in Colorado, we have probably the highest UV level in the country in the middle of the summer. And that is both because of our sun exposure, sunny days that we live here for, but also our elevation. So the percent of new cases differ by age group. I'm going to focus on melanoma for now, but we'll comment on some other more common skin cancers later. The big branch points are non-melanoma skin cancer is a squamous cell or a basal cell skin cancer, and those are much more common, but those have a lower risk of spreading anywhere else and being more serious. So they can be disfiguring because we often have to do big surgeries to remove them, but they have a very low risk of spreading anywhere else in your body and taking your life, versus melanoma has a much higher risk of spreading elsewhere, and that's why it is more serious and can be more deadly. So in terms of melanoma, the average age of diagnosis is 66. And really, we see most people, I would say, in their early 60s to 80s with melanoma. There are absolutely younger folks who get melanoma. And those who are really young in the 20 to 40 range, a lot of us think that there must be some genetic predisposition to not being able to repair that DNA damage. for them to be able to get melanoma so early on in life because it really is more commonly due to chronic sun exposure. And so those who get it in their 60s to 80s, the sun damage is actually happening in their 20s to 40s, and the onset of cancer is later in life. So it's the early sun exposure that actually puts you at higher risk. Um, More common in non-Hispanic whites, and generally more common in men than women, but still high incidences in both, and those with darker skin are not excluded from the risk of getting skin cancer. In fact, Bob Marley had melanoma. In the United States, as I mentioned, there are about a little over 100,000 diagnoses of melanoma per year. This graph here shows that the incidence of melanoma is actually increasing, and we're probably detecting it more, but there is also a higher prevalence of melanoma, but the death rate is decreasing. You can see it's fairly stable over time, but if anything, it is decreasing, and that is likely due to advancements in our therapies, and we'll address those shortly. So here are some interesting maps. They're a little outdated, but this shows the incidence of melanoma across all ages and races and genders in the United States in 1999, with the darker blue suggesting an increased incidence of melanoma. 1999 compared to 2019, so 20 years later, pretty significant increase in the rate of melanoma. And again, this might partially be due to increased detection, but we really do believe it is due to an increased incidence, meaning there are actually more cases related to sun exposure. Can think about all kinds of things that might contribute to that. You know, changes in clothing types that people are wearing, more skin exposure is more common in our younger generations than it was previously. Very significant increased risk of skin cancer of any type with exposure to tanning beds. So just say no. I like this little cartoon here saying you can select your cancer when you hop in the tanning bed. Fortunately, I think these are fading out a little bit more, but they still exist. With one exposure to a tanning bed, it increases your risk of a basal cell cancer by 29%, increased risk of a squamous cell cancer by 67%, and an increased risk of melanoma by 23%. However, if a tanning bed is used before the age of 35, they have shown that it increases your risk of melanoma by 75%. It's increased to 75%. So much higher risk of melanoma if you've had a tanning bed exposure before the age of 35. And the public health departments are looking into this, trying to think, how can we make meaningful interventions to decrease risk of skin cancer because it has such a high cost on our healthcare system. And they really estimate using their epidemiologic statistics that if nobody under the age of 18 used a tanning bed, then we would prevent 61,000 cases of melanoma and 6,000 to 8,000 deaths from melanoma just by eliminating tanning bed use early on in life. And so a lot of states are actually making it illegal to use tanning beds at a certain age. So let's talk a little bit more about the different types of skin cancers. The most common precancerous skin conditions are called actinic keratoses. I didn't write seborrheic keratoses are not actually cancerous, and those are not at increase. Seborrheic keratoses do not increase risk of skin cancer, but those are the ones that kind of look like moles, but almost as if you could scratch them off. We call them the barnacles of life sometimes, that as we age and get more sun exposure over time, it is very common to get various skin spots and dark pigmented areas, colored areas. And so the most common one that we see is called a seborrheic keratosis, but that is not actually precancerous. The actinic keratoses is a precancerous condition. A basal cell carcinoma and a squamous cell carcinoma are technically cancers. They are cells that are dividing that should not be dividing. And they need to be tended to, or they will continue to grow. But both of those have lower risk of metastasizing somewhere else in your body. And then we have melanoma, which does have a higher risk of spreading elsewhere. So to show you some photos, this is an actinic keratosis. These are sort of pink, flat, frequently flat macules on the face or arms. They're sort of pinkish, reddish, and have a sort of a scaly scab appearance to them at times. This is what a dermatologist will frequently give a cream for. It's called a fluorouracil, which actually is a type of chemotherapy. But the cream is frequently prescribed to put all over the face, and it helps treat these precancerous conditions. The next one is a basal cell carcinoma. So this is the most common cancer in the world. At least 3.6 million Americans per year are diagnosed with a basal cell carcinoma. And these are also due to sun exposure over time, most frequently on the face or scalp. And they kind of look, the stereotypical appearance is this sort of pinkish, pearlish papule. So it's a little bump, they're shiny. You can see these little tiny blood vessels in them frequently. Sometimes they're more flesh colored, but this little bump that won't go away, and we get these little tiny blood vessels into them. So this is the most common type of skin cancer that requires a form of intervention, most commonly surgery. But you can see on this picture on the far right how disfiguring they can be. And given the location, the type of surgery can be really challenging. And we'll talk about other tactics to treat skin cancers. But this is why for all cancers, early detection is key, because if we can address it when it's much smaller, it's much easier than, even though this has a very low risk of spreading somewhere else and causing harm to your body overall, it can be very disfiguring, and the subsequent treatments can make that disfiguration worse. So the earlier we tend to it, the smaller the scar. Here are some other pictures of basal cell carcinomas that are a little less obvious. They look a little bit more like those actinic keratoses that we looked at earlier. And then these are squamous cell carcinomas. So these are a little more serious. They have a slightly higher chance of spreading elsewhere, and they can invade more deeply. They can be on the lips, frequently on hands, forearms, face, scalp, similar to the basal cell carcinomas. But these look a little more aggressive appearing, sometimes have more scabs associated with them. For squamous cells, frequently it presents as a scab that just won't heal. So we see them on people all the time on the upper part of the ear, something that hasn't been covered by a hat most of your lifetime. So ear is a very common place for squamous cells. And if you ever have sort of a wound that just doesn't look right. It looks like a pimple that popped and there's a scab, but you haven't had pimples in years. That would be a reason to have these investigated. And then for melanoma, we have the stereotypical ABCDs of melanoma. And melanoma comes from proliferation, meaning cells dividing of melanocytes, which are the dark pigmented chemicals in our skin. They're a type of cell. And if they're dividing too regularly, it appears very dark. So most commonly, melanomas are very dark, can often be black. They are, in terms of the ABCDs, what we're looking for is any sense of asymmetry. So up top on the top row here, we have what are normal appearing moles. We look for symmetry. We want a nice round, something that looks symmetrical versus down here with this melanoma, you can see the borders are irregular and just it is not divided equally. It's asymmetrical. And same with the B stands for borders. So just irregular borders versus up top here, a normal appearing mole usually appears more well circumscribed. Color, frequently these are pigmented, meaning they're dark and can even become more black, but they can have multiple colors. If a mole has multiple colors, we want to make sure we look at it very closely. You can have two moles close to each other, but if one mole seems to have multiple colors, that raises suspicion for melanoma. The diameter, the size of the mole, if this mole is larger than a quarter of an inch, that raises suspicion for melanoma also. And I kind of think of a pencil eraser as a good size estimate. It is normal to have birthmarks and other lesions on the skin that have been there your whole life, and those are not considered increased risk of melanoma. So just to speak towards, not every mole is melanoma, but if you have anything new or changing, growing, very dark, anything concerning for bleeding, that should be evaluated by a dermatologist or at least your primary care provider to take a look and determine if you need it biopsied or if you need a referral to a dermatologist. And so that's the E stands for evolution. If you see anything changing in color, shape, size, texture, again, it is normal as we age to get sunspots, which are frequently sort of these flat, brownish appearing moles. And they may look kind of asymmetrical, but they're just very light. It is if it's darkening and looks like a discrete mole that we're more concerned. Here are a few other pictures of different types of melanoma. There are different types. Some are nodular and they kind of bubble up over the skin. And some grow deeply. Some are called superficial spreading and they kind of spread out over the skin. But here we see a very black one down at the bottom. We can see the various types here on this lower picture on the left. You see the different colors, the irregular borders. Anything like this really should be evaluated by a dermatologist. And so early detection is key when it comes to melanoma, especially. For the other types of cancer, it really does matter too, more because of the type of surgery that might need to be involved. But in terms of melanoma, that does have a risk of spreading. Survival really depends on finding it early. So for a stage 1 melanoma that's detected very early, if we can cut it out completely, there's a 99% chance that when we talk about 5-year survival, that means how many people with that diagnosis are still living at 5 years. And so with a stage 1 melanoma, over 99% of people are still alive at 5 years. They are still at risk of getting another melanoma, so it's incredibly important to continue regular skin checks, but very curable when caught early. A stage 2 to 3 means that the melanoma has invaded a little bit deeper into the skin or has spread to lymph nodes nearby. And once a cancer has spread to the lymph nodes nearby, there's always a higher chance of it coming back, and there's also a higher chance that it has already spread to somewhere else in the body. And so for a stage 2 or 3, meaning depth or ulceration, or stage 3 means it has gone to the lymph nodes nearby in the same geographic area. Survival rates at 5 years. The survival rates did go from 68% to 75%, and that is likely because we have started adding immunotherapy, a treatment that gets to your whole body after removal of a high-risk stage 2 or any stage 3 melanoma. We recommend what we call adjuvant therapy, is a type of systemic therapy that gets to your whole body, and it's been shown to decrease the risk of melanoma from recurring. And that is likely because it's killing any cells that broke away nearby that we just can't see. And then a stage 4 means that cancer has spread to other organs. And still, even with our advanced treatments, 5-year survival rate is about 34%. That is increasing, and survival rates for melanoma very much depend on the melanoma itself and certain molecular features that tell us how this melanoma behaves and its response to immunotherapy, which we'll talk about in a moment. So again, prevention is the most important thing we can do. We don't have many cancers we know how to prevent. And even if you had no sun exposure, you're actually still at risk of melanoma. They can happen from DNA damage without direct sun exposure, but they are most often linked to direct sun exposure over time. And so if there's a cancer we can try to prevent, one way to prevent it is by decreasing your UV radiation exposure. And then early detection is key. If we can find this early, we can treat it early and have a much better chance of a good outcome. So the treatment options for early stage cancers, skin cancers, it is largely surgery, and this is most often tended to by a dermatologist. I do recommend always starting with your primary care doctor. If you've already seen a dermatologist, I generally recommend checking in once a year, depending on your risk for skin cancers. But for anybody who has a concerning mole, I recommend going to your primary care first. They're very good at doing a general overview and then referring you to dermatology if needed. And a lot of primary care doctors can do that first biopsy to tell us what we're dealing with, to tell us then how do we treat it. So for an early stage cancer, if it's a basal or a squamous cell, again, the most common type, we generally proceed with surgery. Sometimes that upfront biopsy, if they get deep enough, is enough. If we have good enough margins, we don't need more advanced surgery. But a very common type of surgery you've likely heard of is called a Mohs surgery. This is done by a specific dermatologist who has had advanced surgical training for Mohs specifically. And these are for more superficial cancers where they're just kind of shaving away a layer at a time of skin. And the pathologist is reviewing it there so that they keep taking a layer and looking at it under the microscope. And once there are no cancer cells left in that layer, then they know that they've finished their surgery and they don't need to cut any deeper. But they don't know when they go into this surgical procedure how many layers they're going to need. They may have an estimate, but they keep going until there are no cancer cells. And so this is the piece where it's less disfiguring if we can catch it early. But you can imagine the difficult location of some of these. If you have a superficial cancer on your forehead, there's not a lot of skin to dig into here, not a lot of tissue otherwise. So they're very skilled technical surgeons, and but the earlier we can get to it, the better chance of a good cosmetic outcome also. And so these have generally very little scarring. When it comes to melanoma, because melanoma can invade deeply and can spread elsewhere, we always recommend a wide local excision. So you can see in this little picture down here on the right, you can see the mole, but we want to get a big football all the way around the mole, so that we get deep enough. You can see this sort of cone here. We want to get a good margin below the deep part of the mole, meaning we want good, healthy tissue. When we take out that mole, we want to know that there are good, healthy cells below it, around it, on all sides, meaning that everything left inside of you is normal, healthy tissue, and that there shouldn't be any cancer cells remaining. And so if these are not done, the wide local excisions are not done with a pathologist on site, because our goal is to get it deep enough that you don't need a pathologist, that we're going to get good margins. But if we go to surgery and we see, that mole, there are, at the sample they took out, there are still cancer cells there, we would recommend an additional surgery to complete that. And so these can be done by some dermatologists. Frequently, the actual wide local excision is done with a general surgeon. So that's who does most of ours here, is our Roaring Fork Surgical Associates. Sometimes plastic surgery can also remove these, depending on where it is. More difficult to get deeper when there's not much tissue to spare. Radiation is an increasingly common treatment for certain cancers like basal cell carcinomas. And this is an example of a patient we've had that our radiation oncologist treated here. I just wanted to show the great cosmetic outcome of really shrinking these moles, and how wonderful they turn out without even cutting in. That is not always the best option, and we do frequently do radiation for squamous cell and basal cell carcinomas, but that is a very interdisciplinary conversation between the radiation oncologist and the dermatologist to figure out what is the best approach, what is going to give this patient the best cosmetic outcome. Again, earlier, better. And sometimes if they're even big enough, the non-melanoma skin cancers don't respond as well to many of our treatments. But if we have a really big area, I think of the top of the scalp as an example, something that is going to have trouble healing with ongoing radiation, sometimes we'll use a very specific type of immunotherapy first, an IV treatment to help shrink it, and then we do the radiation. And then for the advanced stages, that's when you would see a medical oncologist, is if the cancer has spread to the lymph nodes or has some high-risk features, or if it has spread anywhere else in the body. That's where we use more systemic therapies that get to the whole body. So they're mostly intravenous. Immunotherapy is the most common now and has really changed the world of melanoma. Before immunotherapy, in the last 10 to 15 years, we really didn't have good treatment options, and prognosis was very poor if melanoma had spread elsewhere. But now with immunotherapy and people who respond well to immunotherapy, people are living many, many years, and we still don't even have kind of outcome data to see how many years they live. They can have melanoma everywhere that disappears and they're living years later because of this incredible treatment. And it is still evolving. There are pills available for certain types of melanoma that have a mutation that make them very sensitive to certain pills. And rarely do we use chemotherapy. We use radiation depending on where the melanoma or other cancer might be. And then there are a lot of great clinical trials in the pipeline, a lot of really advanced therapies that are going to continue to improve our outcomes, which we're very excited about. So, what can you do now? How can you help protect yourself? Cover up. I really recommend wearing a big hat with a good brim, sunglasses with UV protection because you can get uveal melanoma, which is deeper in the eye, and you don't have any symptoms of that. So I do recommend your getting a vision check intermittently, and when they take a look in the back of the eye, they can look for moles. And then sun protective clothing has really been wonderful. A lot of brands making more products available and just makes it easier than covering up with sunscreen all the time if you can just put a lightweight shirt on that protects you. UV damage is cumulative over time, so little short walks here and there, going to get your mail, going in and out of the grocery store, you're getting constant UV exposure, and that's okay. The whole world is getting UV exposure, and not everybody is getting skin cancers and melanoma. But just being more conscious of those prolonged time periods in the sun when you're getting a lot more exposure, that's when we need to be a little bit more sun conscious. So seek shade from 10 to 2 p.m., 10 a.m. to 2 p.m. The UV rays are the strongest, and so we generally recommend going out early in the morning or later in the afternoon and seeking shade when available. And then sunscreen. When you're out and about, reapplying every 2 hours is important. We do recommend covering up all sun-exposed skin, and an SPF 30 or higher has the best protection. There's a lot of talk about different types of sunscreen and what is safe, what is not. In general, mineral-based sunscreens with zinc and titanium are the most effective and safest for blocking out the harmful UVB rays that cause burns. We think of UVA and UVB rays. UVA rays cause advanced aging or skin damage that you can see, early wrinkles. Those are the ones. And then the UVB rays are the ones that cause burns, but also penetrate deeper and can be more harmful. So a broad spectrum sunscreen is important, and most will label it that. The mineral sunscreens are considered safest because those are the thick, blocky looking ones that reflect sun. But the chemicals themselves are not absorbed versus most of the sprays or oils, the creams you rub in that are a little more transparent, they're not as white. You do kind of absorb some chemicals. So there's a lot of research going on to help us figure out which ones are better. The ones that were more harmful previously were removed from the market. So everything currently is still considered, FDA approved, and GRACE means generally reasonably accepted as safe and effective. So they're doing a lot of research right now. We feel that they're all safe. Mineral-based are a little more likely to not be absorbed and cause possible harm to you in the future, but in general, they don't have as broad of a spectrum in comparison to the more absorbable ones. And we have not seen significant downstream effects from regular sunscreen use. In fact, bigger meta-analysis studies have shown that those who use sunscreen daily are 40 to 50% less likely to develop a skin cancer in their lifetime versus people who only use it intermittently and get burns have a much higher chance of getting skin cancer. Other measures to consider, vitamin B3 or nicotinamide twice daily for those people who have had a non-melanoma skin cancer, like a basal cell or a squamous cell. Those cancers, if you've had one in the past, taking regular vitamin B3 can decrease the risk of a recurrent skin cancer. But that it's only effective when you're actually taking it. So if you only take it for a few months and then stop, it's not as effective. And we don't have proof that it's helpful in preventing other skin cancers or preventing a first cancer. So far, it has only demonstrated efficacy in people who have had a prior skin cancer, and it decreased the risk of recurrence. Interestingly, increased alcohol intake is associated with increased skin cancer, but it's not a direct correlation. They think a big reason for that is more that people who are drinking a lot might be outside more and just partaking in behaviors where they're not as sun conscious for people who drink in excess. But we don't have an exact correlation. And there's some thought looking into NSAIDs, non-steroidals like ibuprofen and aspirin may decrease the risk of skin cancer, but right now we don't have enough sufficient evidence to recommend that, and there are increased risks of taking those medications every day, like gastric ulcers, bleeding. So we want to be conscious of that. The most important thing is finding these early. And so we can all be more sun conscious and try to prevent skin cancers. But you don't have to avoid the sun completely. It is still important to get a little bit of vitamin D, which comes from the sun and our diets. But I recommend getting your spots checked. So if you have any concerning moles, absolutely call your primary care or go to dermatology. And for anybody who has had a skin cancer in the past, basal, squamous, or melanoma, we recommend at least an annual check. Sometimes people need more frequent checks every 6 months or so. Melanoma, melanoma is very near and dear to my heart. My father passed away when he was 36, and my family helped develop this Defeat Melanoma Foundation to raise awareness in his honor. And we've had a lot of really successful projects like putting in screen covers in public areas, sunscreen bottles, hiking trails, and at University of Colorado campuses. So we've made some movements more by making just increasing awareness about melanoma and skin cancers. I mentioned that 1 in 5 people get a kind of skin cancer, and I think we can all think of somebody we know who's had skin cancer. Interestingly, in our small group here at the Cancer Center, 3 of us of a group of 10 or 12 nurses, I want to say 3 have had a parent with a metastatic melanoma. We want to protect our friends, our parents, our children. Now is the time to raise awareness and help increase their sort of skin cancer prevention awareness just by sun conscious behavior. They don't have to, it's okay to get sun exposure, just all in moderation. So thank you. I appreciate your time today. I hope you learned a little bit about skin cancer and the different types we're at risk for. Again, just to summarize, prevention, just being more sun conscious is important. And then early detection is key and increases our risk of our opportunities for a good outcome if we can address it early. So with that, I thank Valley View for supporting Valley View University and the Calaway-Young Cancer Center where I work here. And Right now is a good time to take any questions that were submitted. I have some support here to answer a few questions.
Hey, Dr. Donovan,
Mhm.
does having polymorphic light eruption indicate a higher risk of developing skin cancer?
Polymorphic light eruption. I am not sure I'm familiar with it, what that would be. If that was a treatment for something, I might need clarification on that, and I can look into that. I am polymorphic light eruption. I'm going to need to look into that. Figure out what type of light. That's the type of rays and the radiation we're getting from those rays that increase the risk. So I'm just not sure. Certain things like heat, for example, comes from infrared light, and that's on the red end of the spectrum and creates warmth, but doesn't cause radiation that can penetrate the skin. So it just depends on the frequency of these light rays. So I can't speak towards that. I'm sorry, but I will look into that.
Lots of questions about sunscreen.
Mhm.
So, do you recommend specific brands of sunscreen?
Also a great question. I do not in particular recommend any particular brand. I think it would be good to check in with a dermatologist because they know some brands that work better. I know with working with some of our local dermatologists, we will always say that the most protective is a mineral based, that more blocky appearing that doesn't rub in. But the dermatologists also share with us that they're not as broad spectrum. They don't cover as much. And so challenging. So as of right now, I don't have any brands in particular. I do think Carbondale and Glenwood, Aspen, we have a very sort of naturopathic valley that really cares about environmental health as well. And so both for our physical health and environmental health, they're making a lot more products that are considered reef safe, for example. And I think all of those products are going to be generally safer. So I would say mineral based if you want to minimize any risk of something getting into you, but it is more important to get some sort of coverage. And so, the sprays, we worry that some people inhale a lot of that, the sprays that can be toxic to your lungs down the road. So I generally recommend a cream, and mineral based is better, but any kind of protection is better.
Great. And how about, again, a sunscreen question, is water resistant sunscreen better? And then is the SPF, if it's higher, like 100, is that better than 50?
Great questions. So the um, first question, water resistant is important, especially if you're going to be swimming. We want something that's going to repel, so that you still get the sun protection while you're in the water. So water resistant is important and good to reapply after 2 hours because even if you're swimming around rubbing, it's going to rub off. And so we recommend reapplication. And then, I'm sorry, the second part of the question was
Does the SPF number matter?
SPF does matter. So generally, SPF 30 and higher is going to give us the best coverage. They've shown that over 50 doesn't really protect you significantly more. So in general, the best recommendation is for an SPF of 50, gives us good continuous coverage. So we don't need to spend more money on higher than that, and we're not positive that it really does protect you more. But SPF 15 or lower, not as helpful for prolonged exposure, and certainly the tanning oils that have SPF 4 are not recommended.
Do certain medications increase sun sensitivity?
Great question. Absolutely. Most commonly, the medications that people take that increase sun sensitivity are things like some antibiotics, doxycycline, for example, can increase sun sensitivity, and then some of our chemotherapies. Most often, your provider, if they're prescribing these medications regularly, or if you're on something chronically, they will share if there's an increased risk of sun sensitivity.
Um, so we have a golfer and they sell very thin long sleeve undershirts for sun protection with UV rating for golfers. Any experience with these?
Um, yes, the golf shirts and any kind of there are so many brands now, but any SPF shirt is really helpful because again, you don't have to layer the sunscreen on, and it's due to both the weave of the um, fabric they're using and the density of the weave lead to that sun protection. So they make a lot of rash guards, bathing suits with long sleeve with SPF protection. Same thing, a lot of the hats now have SPF protection, all the golf shirts, tennis shirts, outdoor activity shirts, and you can get them at any outdoor sports stores, but also at Walmart and Target to help protect you. So there are some in a very affordable price range. I live in them in the summer. They make life so much easier.
Um, so one type of Eucerin skin cream mentions increased photosensitivity. On the other hand, some skin moisturizers do include sunscreen. Any thoughts about skin moisturizers in association with skin cancer?
Great question. I do not know of an increased risk of skin cancer with certain moisturizers. Um, Again, a lot of this depends on how deeply the moisturizers penetrate into the skin. And I also don't know about photosensitivity with them, meaning what makes you more sensitive to the light. Um, Good questions for dermatologists, but in general, there are some advanced lotions you can buy that have certain properties, like they're more basic or more acidic, and that's to help treat a certain skin condition. And those can, it might make you more photosensitive. I think of more medications, like certain things we use to treat acne, for example, anything with, or aging. So a lot of people use products that have retinol, to help treat sun damage and minimize fine lines, but those actually do make you more sensitive to the sun and can cause more harm. So I would discuss it with your dermatologist. Um, but in general, most over-the-counter lotions do not increase sensitivity or risk of skin cancer.
Is tinted sunscreen just as safe as normal sunscreen?
Yes, tinted sunscreen should be just as safe as normal sunscreen.
How is Valley View equipped to treat skin cancer here?
Great, great question. We depends on the stage, but I would say ranging really a lot of players who can help um, treat any kind of skin cancer, starting from primary care doctors who often do the first evaluation and refer you to dermatology if needed. At Valley View, we don't have a specific dermatologist, but we work most closely with others in the Valley, mostly at GMA. We have Dr. Kelly Thomas, Glenwood Medical Associates, Glenwood Dermatology, Dr. Krieger, Aspen Dermatology. We have a whole slew of dermatologists that we really appreciate collaborating with throughout the Valley. And then our general surgeons here at Valley View and our plastic surgeons both help with certain surgical resections. Occasionally, we work with our radiation oncologist to provide local treatments to certain areas. And then you would see a medical oncologist if you needed any kind of systemic therapy. So you'd see us here in the Cancer Center if you needed any kind of systemic therapy for a cancer, meaning an intravenous treatment. And that really, we do give those for stage 2 and higher melanomas now. So we're getting more involved as well.
So we'll make this our last question, Dr. Donovan. Where do you see patients and how should people schedule a skin check?
Great. Um, so I will start with the skin check question. I recommend starting with your primary care or a dermatologist. If you have a very concerning mole that you're worried about, I would go right. You can self-refer to a dermatologist. But to expedite things, sometimes it takes a while to get into dermatology. I would start with your primary care doctor to schedule a skin check. And then in terms of where would I see a patient? I see patients here at the Calaway-Young Cancer Center here in Glenwood at Valley View Hospital um, for any consultations or treatments. We also see patients we have a clinic in Aspen and Rifle and also Craig. So we're spreading out our ability to provide treatments to those who need it. Okay. Thank you again for your time today. We really appreciate it. I hope you learned something and can move forward to take action for your health. We have a few announcements. We'd love to hear your feedback on today's presentation. So if you have time to fill out the quick survey, it'll appear right after the webinar has ended. You'll receive an email with the recording of the webinar within the next 24 hours. And our next Valley View University presentation is tomorrow at 12 p.m. with our interventional gastroenterologist, good friend, Dr. Bob Edemad, who will be presenting on the gut biome and sort of information about diet. That should be very interesting. And then I just wanted to make an announcement that our next Calaway-Young Cancer Center event is to celebrate survivorship. And that's on June 17th from 4 to 6 p.m. at Sayer Park here in Glenwood. We can join all members of our Calaway-Young Cancer Center team to appreciate the patients we've treated and survivors from across the community for live music, food, and a tribute to honor survivors past and present. And so even if you are currently battling a cancer, you are a survivor. If you've had a skin cancer removed or any other kind of cancer, you are a survivor, and we want to celebrate you. So thank you for your time. I hope you have a great afternoon, and I hope I see you out and about in the community. And if you ever do need our care, we're here for you. Thank you so much.